So this is our fourth video on our topic, on our session, on our playlist, which is called the amblyopia. And in the last video we have discussed about the different types of amblyopia, but in this video we are going to learn about the remaining types of amblyopia. Like we have left about the ametropic amblyopia, right, and the light deprivation amblyopia. So remember, what is ametropic amblyopia? Ametropic amblyopia, you know very well that what is ametropia. Ametropia is refractive errors. We have three different refractive errors. We have hypermetropia, we have myopia, and we have astigmatism. Remember that if you have high prescription, if you have high number of hypermetropia or myopia or astigmatism, that can lead you towards the amblyopia. Remember that if we talk about the bilateral ametropic amblyopia, then for example, if you have hypermetropia, +5 here and +5 here, you have the same prescription here and here because it is bilateral. So +5 bilateral +5 hyperopic prescription can lead you towards amblyopia in the early age, right? We have discussed in detail that hyperopia is more in danger to amblyopia. Hyperopia can lead you towards amblyopia rapidly, but comparatively myopia, so in case of myopia, for example, if you have -10 here and -10 here, that can lead you towards the amblyopia in younger age, right? And if you have astigmatism of 2.5 diopters or more, then this prescription of astigmatism, right, can lead you towards the amblyopia in younger age. So that is all about the ametropic amblyopia. So in a very simple way, if you have high prescription of myopia or hypermetropia or astigmatism, these ametropic conditions can lead you towards the amblyopia, right? And what is light deprivation amblyopia? Light deprivation amblyopia, as name implies, that light deprivation, deficiency of light stimulus, right? So you can see everything with the help of the light, right? I'm making this video because I have illumination in this room, in this studio, right? So the light is actually the stimulus. With the help of this stimulus, actually with the help of the light, we can see everything, right? You can see this whiteboard, you can read these lines on my whiteboard, right? So this is light, right? And the light is very important stimulus for vision, right? If there is a deprivation, if there is deficiency of light, you will be unable to see anything, right? So light deprivation amblyopia, what are the causes of light deprivation amblyopia? For example, if you have a unilateral ptosis, right, the drooping of upper eyelid, right, this can lead you towards amblyopia. If you have unilateral or bilateral cataract, mature cataract or hypermature cataract, then this mature or hypermature cataract in younger age, in 1 year or 2 years of age, or at the time of birth, this can lead you towards the light deprivation amblyopia. So these are some examples of light deprivation amblyopia. And now this video is about that how can we diagnose the critical situation, the critical abnormality, you can say, a sort of abnormality which is called amblyopia. How can we diagnose the amblyopia? Remember that the early diagnosis is very important. The early diagnosis, I repeat, the early diagnosis is very important to treat or to manage amblyopia. And now we will start a very important part of this video, which is how to diagnose an amblyopic patient. And it's very simple that the diagnosis will be there. The diagnosis will be started with the help of the visual acuity. Actually, the visual acuity is the factor, and with the help of the visual acuity, we can differentiate that either this patient is of amblyopia or not, right? So this is the visual acuity which will decide that patient is amblyopic or non-amblyopics, right? And the next thing is screening. Screening is very important. Remember that in preschool children, right, in preschool children, in pre-verbal children, screening is very important to diagnose, to actually for the early diagnosis of the amblyopia. Screening is very important, right? So if you have a child, if you have a kid of 2 years or less than 2 years, the screening of amblyopia is very important, right? If you have child of 2 years or less than 2 years, screening is very important. And then after 2 years of age, screening must be done every 2 years of the age, right? So screening is very important to diagnose or to treat or manage amblyopia, right? And the ideal age for the treatment or management of the amblyopia is first decade. The first 10 years are very important to diagnose, to treat amblyopia, right? But if your amblyopia diagnosed at the age of 15 years, at the age of like 20 years or 25 years of age, the prognosis is very bad then, right? So first decade of life is very important to diagnose and treat and management of amblyopia, right? And now we will discuss about the visual acuity. How can we measure, how can we record the visual acuity in amblyopic patient, right? So first of all, we'll discuss about the visual acuity, and the first point in visual acuity is if there is two line difference on Snellen chart, right? So for example, if you have two eyes, everyone has two eyes actually. So if there is two lines difference between the visual acuity on Snellen chart, you are recording the visual acuity, right? In 5 years or 10 years of age, like you occlude one eye and the patient is looking at the Snellen chart with one eye, and this eye got 6/6 of vision and this eye got 6/12 of vision. So there is two line difference between the two eyes. So this is somehow an indication of amblyopia, right? And in the lazy eye, which is not improving, right, which has the lesser visual acuity, is not improving with the help of the lenses, right, with the help of the pinhole, there is no any improvement. Remember that again. For example, this eye got 6/6 of visual acuity and this eye got 6/12 of visual acuity, and with the help of the refraction, this eye is not improving with the lenses and with the pinhole as well. So this is an indication of amblyopia. This could be the indication of amblyopia, right? So there must be two lines difference on Snellen chart. There must be two lines or more than two lines. It could be more than as well on Snellen chart, right? And for bilateral, this line was about the monocular, right? Two line difference between the two eyes. But if there is bilateral amblyopia, so for bilateral amblyopia, the visual acuity could be 6/12 or less than in two eyes. For example, I have 6/18 visual acuity in this eye, 6/18 of visual acuity in this eye. So this can also leads me towards amblyopia in the early age, right? And now we will discuss about how to record visual acuity in different age groups. Like for example, if we have an individual which is pre-verbal, which cannot narrate a word even, which is not which is a pre-verbal actually, right? So first of all, there is a fixation and following. What is fixation and following? This is a procedure. This is fixation and following test. So for example, if you have a child which is non-verbal, which is pre-verbal, he cannot speak, right? Pre-verbal, right? So how will we record or how will we measure the visual acuity in that child, right? So what we will do, we will occlude one eye, right? If I have a child in my lap, I will occlude one eye and I'll fixate the object. I will move the object right and left, up and down, right? So if your child, one eye is occluded, right? He is looking with the one eye, right? And you are moving your objects up and down, right and left. And if your child is fixating that object, you are moving around, then it means that visual acuity is good, the visual acuity is fine. But if the eye is fixating but in a very lazy way, right, so it means that the visual acuity is not good. So this could be the indication of the amblyopia. So this is called fixation and following behavior, or fixation and following test. So you will repeat the same thing with the fellow eye. You will occlude one eye and you will move the object around, and if your child is moving his eyes or her eyes in terms of that object, right, if you are moving the object in the left and he's moving his eye towards left, and if you are moving the object in right, he's moving his eyes towards right side, so it means the visual acuity is good, right? But if he or she is not fixating the object, right, it means that there could be a lesser visual acuity in that child, or this could be the indication of the amblyopia, right? I hope you understand. And the next is comparison of two objects, right? You will make your child to see the two objects, right? As you can see in the figure, this is a plane chart and this is a stripped chart, a chart with the pattern. So obviously your child will prefer to see to the stripped or pattern chart, right, as compared to the plain chart, as you can see in the figure. And the next is fixation behavior. What is fixation behavior? We have three different phenomena. We have C, S and M. What is C, S and M? C for central, S for steadiness actually, and M for maintenance, right, or maintain. Fixation behavior is the CSM, C for central. You will see that when you will move the object, you will see that either the patient is looking with the phobia or not, either he's following that object or not with the center of his eyes, right? So this will make you to see that your patient is actually maintaining his, or your patient is looking the object with the central portion with the phobia or not. So this is central, right? So the vision, actually the vision is central or not, right? Is there any strabismus in there or not, right? You will differentiate. And next is steadiness, and in steadiness you will see that there is a stable eye position or not, right? In your child there is a stable eye position or not, your eye is centered or not, right? And in maintain or maintenance, you will see that either there is nystagmus or not. You will observe that when you will make your child, when you make your child to look, to fixate at the object, you will observe that eye is moving or not, to and fro. You will observe that patient is nystagmus or non-nystagmus, right? So these are three different things: centered, steady, and maintain, right? And the last one is preferential looking test. Preferential looking test, I have a detailed video on this test. The link is in the behavior. You can see the thumbnail in the video. It is the same that you will make your child to see at two different patterns, at two different charts. One is plain chart, another one is stripped or pattern charts. And obviously your patient will prefer to see, to watch the pattern, the chart with the pattern, right? So these are different you can say methods to record or measure the visual acuity in pre-verbal children, right? Remember that infants will prefer pattern rather than simple stimulus, as we have discussed that the infants, right, the individual with less than 1 year of age, he or she will always prefer the pattern or stripped pattern charts as compared to the simple stimulus, right? Like Taylor cards, as you can see in the figure, and Cardiff cards, as you can see in the figure. And now we will discuss that how we can record the visual acuity in the verbal children, right? So in verbal children, the visual acuity must be measured from the distance of 4 meters. As you know very well that in logmar or ETDRS, we always record visual acuity at 4 meters. So 4 meters, the compliance is very good at 4 meters as compared to the 6 meters, right? So number one. Number two is in 2 to 3 years of age, the picture cards or crowding charts are very important, right? The results are very good, results are very best if you use picture cards or crowding charts, right, at the age of 2 or 3 years, right? And in older patients, always use crowding letter for the best compliance, right, for the best results in visual acuity, right? And then after that, we will learn that what is actually the crowding phenomena now. So crowding phenomena, remember that if you want to diagnose, if you want to make a clear diagnosis between amblyopic patient and non-amblyopic patient, so crowding phenomena is very important. Crowding phenomena is actually the thing which will differentiate a amblyopic patient from a non-amblyopic patient, right? How? Remember that if there is, if my this hand is amblyopic patient and this I got non-amblyopic patient, right? So if I make my amblyopic patient to sit before a Snellen chart, and you know very well the specifications and properties of Snellen chart, we have only one letter at the top, then two letter in second line, and three letter and four letter, and then so on, right? So there is no any specific crowding in the Snellen chart. So visual acuity somehow better on Snellen charts, or you can say on non-crowding charts. But if you make that amblyopic patient to sit before a chart which is crowding chart, as you can see in the figure, so the visual acuity will be lesser than the Snellen chart. So crowding phenomena is very important. Always remember that the amblyopic patient will always face difficulties to see, to read the crowding charts, right? So this is called the crowding phenomena. And now some important tests for the correction or for the treatment or management or for diagnosing the amblyopia, which we will discuss in the next important videos of this playlist or this session, which are, if you want to evaluate the stereopsis, we have Titmus fly test, we have TNO, and another test we have Worth 4 dot test. We will discuss in the next videos. And if you want to evaluate the either the patient is strabismic or not, or if he or she is strabismic, which type of strabismus is there, either it is ESO or EXO or hyper or hypo, So we have different tests to evaluate the deviation, which are Hirschberg test, which we have Krimsky test, we have cover and cover test, and we have alternate cover test, we have prism cover test, right? And we will discuss all the things, we will learn about all these tests in the upcoming videos, but in this video we are moving towards that how we can proceed our refraction in amblyopic patient. And now we will discuss about the treatment in amblyopia, that how can we treat or how can we manage the amblyopia patient, right? So remember that, again the word is there, early diagnosis. Remember that early diagnosis is the key to treatment. Early diagnosis is key to management of the amblyopia. He's saying that studies have shown that anisometropic amblyopia or strabismic amblyopia can be improved with the help of the early diagnosis. If you early diagnose the strabismic amblyopia, if you have early diagnosed the anisometropic amblyopia, so there are 100% chances to improve the vision in amblyopic patient in terms of anisometropic amblyopia or in terms of the strabismic amblyopia, right? And what should be our principles of treatment in amblyopic patient? Remember that our first priority is that removal of the cause. For example, if a ptosis is there, you have to treat the ptosis. If you see that there is a unilateral or bilateral mature cataract is there in a child, you have to remove that cataract, right? If you see that there is a corneal opacity is there, you have to remove that corneal opacity. So we have to remove the cause of amblyopia. First of all, this is the first principle for the treatment, for the management of amblyopia, right? And the second one is promote the amblyopic eye to see. You have to promote the amblyopic eye. For example, this eye is better eye, this eye is lazy eye or amblyopic eye. So you have to occlude the better eye and you will make the patient to see with the lazy eye. You have to make your patient to see with the amblyopic eye. So right, it is actually the promotion the amblyopic eye to see, right? And last but not the least, the refractive error correction. Remember that the first mode of treatment should be the correction of refractive errors, right? If you have ptosis, you will treat ptosis, okay, but first of all you will manage the refractive errors. If your patient got myopia, you will treat myopia. If your patient got hypermetropia, you will treat hypermetropia. If your patient got astigmatism, you will treat the astigmatism, right? So this is the key. So these three things are actually the key to treat amblyopia or to manage amblyopia. So now we have different studies. I have taken these lines from a research. There is Pediatric Eye Disease Investigator Group, PEDIG. So this group make many researches. They worked very hard on investigate amblyopia, and they are saying that the crux of their research is, he's saying that refractive correction alone in anisometropic amblyopia has 27% chances to improve. Remember that. He's saying that only refractive correction. You are not patching your eye, you are not occluding your better eye, you are only giving the best prescription to the patient. In which patient? In anisometropic amblyopic patient. So for example, you find a patient with anisometropic amblyopia and you just gave him the anisometropic prescription, and the chances with the refractive treatment only is 27% without any patching. But it doesn't mean that you will not patch his or her eye. Patch his or her eye, but this is actually the importance. I want to make you to come to so actually this is the importance of refractive treatment, right? Without any patching, if you give prescription, if you give 100% prescription to the anisometropic patient, right, then there are 27% chances to improvement, right? So another study is, he's saying that refractive correction alone in bilateral refractive amblyopia, right? So if you got a patient having bilateral refractive amblyopia, high prescription in right, high prescription in left, and you just gave him a full correction prescription to that patient without any patching, without any occlusion, there are 32% chances to improve the visual acuity without any patching. But again, it doesn't mean that you will not patch the patient's eye, you will not occlude the patient's eye, right? So this is just the importance of the refractive correction. First of all, you will treat the refractive error, that's it. Then you will move towards the occlusion therapy, the penalization, etc. So this is actually the importance of the refractive treatment. But if there is no any improvement with the refractive treatment, then you will move towards the occlusion therapy, right? You will patch your eye. And how you will patch your patient's eye? First of all, we will discuss that how many types of patching are there. We have adhesive skin patches, as you can see in the figure. We have opticludes, we have occluders in terms of spectacles and contact lenses, and for the patching, for the occlusion, you have to motivate your child, you have to motivate that patient, which is a child, which is a baby, right? You have to motivate your attendees, right? You have to motivate the parents of the child actually, right? So you, being a good optometrist, this is your duty to motivate the patient and their parents. And now we will discuss the different lines from the research articles in terms of amblyopia. We have ATS studies. ATS mean amblyopia treatment studies. So amblyopia ATS studies saying that we have three different studies. The first is, in the first studies, they compared two groups and they compared 2 hours patching with the 6 hours patching. They make two groups, one is of 2 hours patching and one is of 6 hours patching in moderate amblyopia, right? And after 4 months, they find that both groups improves, right? But better compliance was in 2 hours patching, right? So the first research, because you know very well this is the age of research, right? So that's why I find some research articles here and we are studying that research article. So first of all, in ATS studies, they make two different groups, right? Group number 1 and group number 2. So in group number 1, they preferred 2 hours patching, they recommend 2 hours patching, and in group number 2, they recommend 6 hours of patching. And after 4 months, they find the results, and the results was that both of the groups, the improvement was there in both of the groups, but the better compliance was there in 2 hours patching, right? They find that the 2 hours patching is better than the 6 hours patching, but in moderate amblyopia. So it means that in moderate amblyopia, 2 hours patching or 3 hours patching is fine, right? So another study was study number 2. They again compared 6 hours patching with full-time patching and they make two different groups, group number 1 and group number 2. So in first group, they recommend 6 hours patching, and in the group number 2, they recommend full-time patching. And after 4 months, both the groups show improvements. Both the groups show improvement of at least 4 lines, but with better compliance in 6 hours group. But the better compliance was there in 6 hours patching. So it means that in severe amblyopia, 6 hours patching is more preferable than full-time patching, right? So this was a study. And the last study was they compared 2 hours patching in moderate and severe amblyopia. So there were two types of amblyopic patients. One was moderate and other one was the severe amblyopia, and they recommend the same hours, 2 hours in moderate, 2 hours in severe amblyopia, and they observe the improvement in the both groups, right? So with these three studies, we concluded that the crux of these three studies was that the patching is actually the best modality to treat amblyopia, right? Patching therapy, actually what we do in patching, we always occlude the better eye, right? We will occlude the better eye and will make the patient to see with the amblyopic eye. This is patching, right? So it depends on the severity, it depends on the age, it depends on the compliance, that how many hours we have to patch the better eye, right? Either we have to patch this eye for 2 hours, for 4 hours, for 6 hours, or we have to go for full-time patching, right? So if there is moderate mild amblyopia, so there is 2 hours are more than enough for a day, right? So if there is a severe amblyopia, you can say, or first it is if mild, then 2 hours. If there is moderate, then 2 or more than 2 hours. But if there is severe amblyopia, then we will go for 6 hours patching to treat amblyopia, right? So studies shown that the patching is the best modality to treat amblyopia, but the important point is, but part-time modality is the best option. Remember that the part-time modality is the best option, right? Then studies shows that the results of these studies was treat refractive error first. As we have discussed in the previous section of this video, that we have to treat the refractive error, right, at priority. And again, that the PADIG studies recommend 2 hours patching in moderate and 6 hours patching in the severe amblyopia. So this studies results that if there is moderate amblyopia, you will go for 2 hours patching, and if the amblyopia is of severe amblyopia, then you will go for 6 hours patching, right? And again, follow-up. What should be the follow-up? Remember that the follow-up depends upon the age of the patient. What is the age of the patient? For example, if the patient's age is 1 year or 2 years, so we need follow-ups, right? And severity means if amblyopia is if there is a severe amblyopia, then we will make the patient to come on follow-ups. And compliance, if the compliance is good, if the patient is following your instructions, if the parents of the patients are following your instructions, then follow-up can be of 3 months or 4 months, right? But if compliance is not good, they are not following your instructions, then there will be consecutive follow-ups should be there, right? And the last, if there is no improvement with the patching, then you will find another modality, and another modality is the penalization. And in the next section of the video, we will discuss about the penalization. And now we will discuss about the penalization. The penalization actually, the purpose of the penalization actually the defocusing the better eye by therapeutic purposes, by the therapeutic drugs. Actually, we will defocus the better eye. It means that we will put the atropine, we will put the drugs in the better eye, right? Then the patient will see with the lazy eye or with the amblyopic eye. Is very simple, right? So in as we are doing in the patching, we were occluding the better eye, right? And in penalization, we will put the drugs in the better eye. We will defocus the better eye with the help of the drugs, right? So the first point is we will defocus the better eye with the help of the therapeutics, right? So cycloplegia with the help of the atropine or glass lenses. So we will make our eyes cycloplegic, right? So we will put atropine, and you know very well that what atropine will do in the eye, it will dilate the pupil and it will relax the accommodation. So the image will be totally blurred in the better eye, and the patient will patient will see with the help of the amblyopic or lazy eye. So this is our principle. And now we will discuss about the indications in penalizations or indications of penalization. So obviously, if your patient or the parents of the patients are not following your instructions, right? If compliance about the patching is 0 from the patient or from the parents of the patient, then you will move towards the penalization, right? You will put the eye drops in the patient's eye, right? So disadvantages, we have some disadvantages of the penalizations. The first disadvantage is systemic absorption. So actually the atropine is a type of drug, so it could be absorbed systemically and it can cause severe adverse effects also, right? And the next is occlusion amblyopia, right? If you are continuously putting or instilling the atropine in the better eye, so it can make your better eye towards amblyopia as well, the reverse amblyopia actually. So now we have 3 different studies about the penalizations. Then we will make our results of these studies. So the ATS means amblyopia treatment studies. So the study number 1 was they compared 2 things: 1% daily atropine or versus 6 hours patching. So they compare 2 things. One is they compare 1% daily atropine. They instill the atropine inside the patient's eye, 1% actually the atropine, right? And then in next patients, they patch the eye for the 6 hours in moderate amblyopia, right? So in moderate amblyopia, so we have 2 different patients with moderate amblyopia, with moderate amblyopia. In this patient, they instill 1% atropine on the daily basis, and in this patient, they recommend 6 hours patching, and they compare 2 patients with the moderate amblyopia, and the results was in 2 years of age, the age of the patients was 2 years, 86% vision improvement was there with the patching. Remember that patching, the patient with the patching improves his vision 86%, 6%, right? And 83% improvement was there with the atropine, right? So it means that patching is somehow better than the penalization. And the next study was, they compared again the two things, daily use of atropine versus weekend use of atropine, and the results were the same, right? They compared two different patients. In one patient they instill atropine on daily basis, and in one patient they instill the atropine on weekend basis, and the results were almost the same in the both patients. And the third study was, they compared refractive correction alone, right? So the first patient, two patients with amblyopia were there, and in one patient they just correct the refraction, they just correct the refractive error, right? And in other patient they uh, uh, and in other patient they put atropine, they follow atropization. Atropization mean they put atropine in that patient, or they perform penalization. So there were two patients, one they treat just with the refractive error, they just treat the refractive error, and in other patient they just put the atropine, they perform atropization. And in treatment group improvement was 2.8 lines, and in control group improvement was 2.4 lines. So the improvement was almost same in the both of the patients with refractive error alone and with atropization. So the crux of this penalization is actually that the patching is as effective as the penalization, and penalization is as effective as the patching. Both of the procedures are the good. But so let's recall the whole mode of treatment, mode of management of amblyopia. So first of all, our first priority is to diagnose the amblyopia. How to diagnose the amblyopia, and how we will diagnose the amblyopia? We will, if the pre-verbal children are there, we will make different types of visual acuity methods, right? Follow and fixation and all we have discussed. And if the patient is verbal, then we will go for the different crowding charts, right? And how we will diagnose the pre-verbal children? Pinhole is the key. Remember that if your patient is verbal, if your patient is school going, then pinhole is actually the key to diagnose amblyopia. You will put the pinhole before the patient's eye, and if the pinhole, if with the help of the pinhole patient is not improving, right, then it means that this is actually the clue that patient could be of amblyopia. But without any abnormality, like patient visual system is clear, there is no any abnormality, there is no any lesion in the visual system, right? If there is no any structural abnormality in the patient's eye or patient's visual system, and vision is still not improving, that this is called amblyopia, right? So actually the pinhole is actually the key to find that either the patient is of amblyopia, or either the patient is of simple refractive errors. And then we will go for the refraction. Remember that if the patient age is less than 15 years, then you will surely go for cycloplegic refraction. You will go for the atropine, which is a cycloplegic drug. You will go for cyclopentolate, which is also a cycloplegic drug, right? You will instill these drops in the patient's eye, and after 45 minutes you will perform retinoscopy, right? And then you will decide, then you have to give the full correction or not, right? It depends on the age of the patient, it depends on the severity of the amblyopia or refractive error. And after the correction, after the cycloplegic correction, you will go for and if there is no any improvement with the help of the correction, vision is not improved with the cycloplegic refraction, cycloplegic prescription, then you will go for the patching, right? And you will go for patching, and what will you do? You will occlude the patient's better eye, right? You will occlude the patient's better eye. And how many hours you will patch the patient's eye, it depends on the severity of the amblyopia. If there is a mild amblyopia, you will go for 2 hours patching in the better eye. If the amblyopia is moderate, then you will go for 3 hours patching. If amblyopia is severe, the patient is severe amblyopic, then you will go for 6 hours patching or full-time patching. But you will go for alternate patching as well to prevent your patient from reverse amblyopia as well. So if you are occluding the better eye all the time, then your amblyopic eye will improve, but the danger is towards the better eye now, right? So this is called the reverse amblyopia. So you have to prevent your patient's better eye from reverse amblyopia. And if your patient is not following your instructions, the compliance is very bad with the patching, then you will go for penalization. You will instill the drops in the patient's better eye for penalization. Hope this is clear, and we'll make more and more videos with the passage of time on amblyopia. So for now, goodbye. See you in the next video.